Hello, Dr. Liao. Hello, Dr. Liao. Hello, can you hear me?
Hello, John.
Hey, good morning.
Hi, good evening.
Yeah, how's it going?
Yeah, good morning, good evening. Yes.
Yeah, did you work today?
No.
Oh, okay, you had day
Yeah.
off. Great, great,
Yeah.
great.
Yeah. We having a 3-day holiday.
Oh, that's right. And
Yeah.
what is
have
the
a
holiday?
small.
What is the holiday?
Yeah. We have a small festival.
Oh, okay.
Yeah.
Okay, you know you have two inputs to the webinar, right? You have two.
Yes.
Okay,
Yes.
that's normal, huh? Okay,
Yeah.
that's fun. That's
And
fun.
to make sure, in case one buys.
Back up. Okay,
Yeah.
no problem, no problem.
Yes.
But sometimes we have problems because the translator does not mute, and so we can hear the translation.
Ah.
So be careful.
Okay. I know.
Yeah. If I hear it, I may say that we
Yes.
have wait, Dr.
Yeah.
Liao. We have background noise, but it's no
Okay.
problem so far with you. One time it happened with Dr. Takashi, but I'll let you
Oh,
know.
yeah, I know.
I'll let you know. I'll
Okay.
let you know. Okay.
Okay. Okay.
Thank you
Okay.
for
Thank
coming.
you.
Thank you for coming.
Yeah. It's my honor. Yeah. Looking forward.
Okay. Hi, Dr. Liao. Are you there, Dr. Liao?
Hi, John. Hello, John.
Yes, yeah, just so we can communicate during the webcast. You know the chat feature, right?
Yes.
Yeah, I'm going to chat to you right now. I think you probably know it.
Yeah. Chatbot.
Yeah,
Yeah.
yeah, that's to,
I see.
yeah, that's just to communicate with you during the webcast.
Okay.
Okay.
Yeah. I can get a private conversation.
Yeah, it's private between us.
Yeah.
If we have to.
Yes.
Uh, so you're in the program. You're a resident, right? No, are you an attending or a resident, Dr. Liao?
I'm attending.
Oh, okay.
Yeah.
Okay. Okay. I'll keep in contact with the other conferences that would like to have Chinese. Okay.
Okay.
And if Dr. Bin doesn't want to do them, that's okay. I'll look for someone else. But first, I'll go to you to see if you want to do it. Okay.
You mean moderator or
No. Just as a translator.
okay, translator. Okay.
Yeah,
Yes.
yeah. And also, if you want to arrange a conference, that's fine. I'll televise it if you and put it on Neurosurgery TV, and you can do it in Chinese too if you want. Okay.
Okay. Okay, I know. Okay,
Okay.
thank you.
Just let Dr. Zhu know if you want to televise a conference in Chinese on Neurosurgical TV. No problem. We'd love to do it.
Yeah, thank you.
Okay. Okay. We got about 20 minutes.
Mm. Mm.
Welcome, everybody. We start in about 15 minutes. I'll check with Dr. Lanzino. He's an early riser, though. He's probably been up a couple hours already. Okay, there you are. Good morning, Dr. Lanzino. Did you get in okay?
Yes, everything is good.
Yeah, everything's good.
So we're very excited about this.
Good.
Hey, John, my fellow Nicholas Borg will join. If you could upgrade him as a panelist.
Yes, sure.
Okay.
Okay.
He can help us with the chat then and to answer questions. So
Okay.
he'll be right next to me.
Okay.
I like to make sure that everything goes well. I've had from this station lately, I've had some issues with the new Zoom. So if I can
You want to test? You want to test some things?
Yeah.
Yeah. Go ahead.
Okay, so I'll go ahead. Let me see. I'll share my screen.
Good morning, Warlix. Yeah, looks good.
Okay, you see.
Yeah. Perfect.
There are no issues with the slides.
No.
Everything looks good.
Yeah, looks really good. Really good.
Let me see. There is a video. So.
Okay. Yeah, I gotta.
Okay, here. Let's see if the video goes well and if there are no.
Okay.
It's going smoothly or.
Yes, very smoothly. Is there no sound right in the video?
No sound, correct.
Okay, then no problem. It's very good.
Right.
You've got a good band. You've got a good internet connection.
Okay, sounds good. Great. All right, we're all set then.
Yeah, you can tell if someone has a poor internet connection, the videos are slow.
Right.
They fall off. So if you have someone with a weak connection, it's difficult to have a video for them to present a video. But anyways, okay, it looks good. What time do you get up in the morning? That's what I wanted to ask you.
Usually around this time.
Okay.
You know, like what happened is that actually I went back home to Italy. And so every time I come back from Europe for the next month, I usually wake up an hour earlier than. So this month I've been waking up about 5 o'clock, which is usually an hour earlier than.
Oh, okay. I'll get you off the screen share for now, okay? And Warlix is going to be moderating. Hi, hey Warlix. Warlix, are you there? You got to unmute, Warlix.
Yes.
You know Warlix, right, Dr. Lanzino?
Sure. Yes. Hey, Warlix.
She's a famous artist.
Hi. No. I'm neurosurgeon.
And a neurosurgeon, famous artist and neurosurgeon.
Yeah, it's
every time we do a webinar, she has to run and do some big cases.
That's right. Well, we need someone like Warlix that kind of knows more neurosurgery more than me, especially with this discussion. I'm not a trained neurosurgeon, so it's best that Warlix kind of handle that, right, Warlix?
Yeah, but most of people know me as an artist instead, but actually my main job still surgery and neurovascular.
Yeah, your interest is neurovascular, right, Warlix, or is that one of the interests?
I just finished my specialties endovascular, so I do both neurovascular surgery and endovascular. Yeah.
Dr. Duong, how you doing? Haven't seen you from Vietnam for a while.
Hi, John. Hi, Professor Lanzino.
Hey,
have you met Duong before?
Yes, I met Dr. Lanzino 3 years ago in Beijing.
Oh, excellent. So it's time to revisit.
Yeah. This is the WFNS 2019, the last meeting.
Yeah, I haven't seen you in a while, but he always shows me some of the cases he's doing. Very impressive.
Oh, great.
Yeah.
I told him that once things are normalized, I have to go and spend at least 10 days with them.
Oh man, Vietnam looks gorgeous, huh?
Yeah, thank you.
Wow.
I'd like to introduce my fellow Nick Borg to everybody. Nick is a neurosurgeon, came from the UK and spending a few months with us, full year with us. So,
morning, everybody. How you doing?
Good morning, Nicholas. Nice to meet you.
Nice to meet you.
I'm Dr. Bennett.
Morning.
This
Hello.
is Warlick's the artist and neurosurgeon and host.
Surgeon.
Okay, we got 7 minutes. Yeah, I'm gonna put you as a co-host, Nick.
That's good.
Let's see here. Okay, where are you from, Nick? Oh, go ahead.
No.
Sorry, I trained in the UK. I finished my residency in Southampton last August. I was meant to come here in August, but got delayed a little bit by COVID, and eventually made it here 2 or 3 months ago.
Oh, okay. Okay, you're doing a fellowship at Mayo for a while.
Love to go there.
Yeah. Oh, it's great.
Yeah, Warlick, you got to go to Mayo.
It's great fun.
Yeah, but
Great
it's
fun.
like stuck with all the COVID. Even
Right.
like I have a promise with Professor Shinimura, I still cannot go to Japan because I was still with COVID.
Japan shut down. Okay.
Warlocks. So this is what I like to do. This is intended to be like a very informal discussion about a topic, and using a case as the excuse for the discussion. So it's very informal. Feel free to interrupt me at any time. And Nick will help us also monitoring the chat, and we can basically stop and answer questions anytime, or we can wait toward the end of one of the sections. Any way we like to do it. My hope is that over time, as everybody feels comfortable, people will feel, might want to share a case, they have done it. They can send to us in advance so that we can prepare a organized discussion. But that's the option. The hope is to do something a little bit different than the usual lecture-based webinar. And I will plug a few articles to stress some of the points. Of course, there will be a little bit of bias about the work that we are doing, if there is something newer that we are doing on the specific topic and so forth. So.
Oh, good. Ben's here.
That's fantastic.
Hey, Ben.
Ben is here. Welcome, Dr. Ben. Dr. Ben, you there?
Hey, my friend.
Hi, Professor Lanzino. Nice to meet you. Hi.
Good morning.
Yeah, good morning.
We have Dr.
I'm in
Liao.
another city, in Zunyi.
I see there is Dr. Lapira also. Biaggia was my fellow in 2016. I see her. She's.
I'll get that.
Hello, everybody. Thank you, Dr. Lanzino, to introduce me.
Hey, Biaggia.
Ciao. So nice to be there. Thank you very much. It could be a great occasion for us to learn, as usual, when you talk.
Usually, when I do one of these things, though, I'm the one who learns the most. So.
No. We will learn a lot. Thank you. So Italy is here for you.
Three minutes we start. Have you noticed, Dr. Lanzino, a difference in the Zoom? Have you noticed a version?
Yeah, I noticed that with the new updates, we have to be a little bit more careful because there can be more issues when you go and share your presentations.
Okay. You noticed that? I haven't noticed that. One thing about what you're proposing, you just be patient because it'll, I think, take time for people to get comfortable.
Absolutely, yeah. Yeah,
So-
it will take a few sessions to, get the message across, and then
Yeah, I'm sure you'll explain that when you open what you're trying to do. So, which is great. So trying something different.
Hi, Professor Lanzino.
yes,
Yeah, because today I am in another city in Chunyi, so we have a conference here, and
Okay.
maybe I will left later.
okay,
So I couldn't join you for the whole webinar.
okay.
I say sorry for you.
Yeah, well, no. Thanks for being here. I know you are very, very busy. No, so no bypasses today.
I
for
know
you?
that's what I asked
No,
him.
no. Today no.
Five is a slow day. It's 5 is a slow day.
Yeah.
You know Warlick's Dr. Ben, right? Warlick's, you there?
Yeah.
You met Ben before, right?
Oh, yes, from the webcast.
Okay.
Does Dr. Takeshi come today?
To who?
Dr. Takeshi?
I don't see him so far. I may have let him in, but didn't notice. Takeshi? Oh, you mean a Japanese?
Yes.
Yes, yeah.
No, I think unfortunately he had a case. He may join us in a while. So unfortunately, we had a conflict. Yeah, well, let's just introduce Dr. Lanzino and basically what he's trying to do, and then introduce him, and then run the thing. Okay.
Okay.
And don't eat on camera.
Huh?
Don't eat on camera. You don't have any food there, do you?
No, but it's 6 p.m. here in Thailand.
Okay,
Yeah.
here we go. 10, 9. After I finish counting, take it, okay? 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Okay. Welcome to Neurosurgical TV today. Today we have a really great webinar from Professor Giuseppe Lanzino. He is a professor from the Mayo Clinic, Rochester, Minnesota, USA. Today, we will have a great webinar about neurovascular case study, a series which we have a lot of case presented by him, in which it's based on the case. And if you feel free, you can give discussions. And if you have questions or things to discuss, please feel free to leave a comment or ask the questions. So yes, please, Professor Lanzino.
Thank you, Warlocks. Thank you, John, for making this possible. Good morning and good evening to all the friends that are connected. So I think what we would like to do is basically we would like to have to do something a little bit different than the classical webinar and have an informal discussion based on a case. And I'd like for everybody to feel free anytime to stop me, ask questions, make comments. And the goal and the hope is that over time, any participants who would like to share an interesting case will submit their own cases so that we can organize a discussion around the case. And this way we can all learn together in a very interactive, relaxed fashion. And of course, here and there, whenever possible, I will put some plugs to articles that would stress some of the points that we are making. So the case that we'll be sharing today, it's an 18-year-old who presented with really start having some nausea and vomiting. And then is an 18-year-old, so is very active. So the true timing of everything else was a little bit difficult to pinpoint. But what was clear is that he started with nausea and vomiting that persisted, and was thought to have some gastrointestinal upset. Then he developed a numbness involving both arms and hands, and eventually started developing weakness in his legs, as well as hiccups. And the weakness progressed throughout a course of a day, to the point that he's graduating from high school. So he went to the last year, end of the year party, but his friends had to take him back home because he was barely able to stand and walk. So here, what I like to stress with this is that too often we are so concerned about the technical aspects of the procedure of surgery, but we neglect the importance really in the overall scheme of things, in the decision making, in the care of a patient. We tend to neglect the importance of the history. And as you will see in this particular case, the history is very important, because just based on this, you can localize exactly where the lesion might be. And you can see here that he has a hemorrhagic lesion in the lower medulla. And being a young person that has a fairly large hemorrhagic lesion, we most likely suspect that he's suffering from a bleed from a cavernous malformation. Now, this is, as I said, it's a very nice correlation between the imaging findings, the clinical, and the location of the cavernous malformation. Because remember, he started with the nausea and vomiting. So the actual, the cavernous malformation, it's in the lower medulla, and that's really where the area postrema is located. So when I look at an MRI in a patient with the cavernous malformation, I, especially one that has bled, I try to understand where is the actual cavernous malformation. And in this particular patient, you can see that the actual lesion, it's probably this one. Can you see my arrow where it looks? Good.
I can see that, doctor.
Oh, good.
Yes.
So that's a consideration. And that's particularly important in those patients that have had the prior bleeds. We are following, they come back, they have another bleed. Then it's very important, I find very important, to go and look at the original studies, because that original studies is more likely to tell me where is the actual cavernous malformation, the actual mulberry lesion. Why that is important? Well, because while it's easy to evacuate the more acute hemorrhage, it's the actual cavernous malformation that especially, and we will discuss about that, in the established form, it's really stuck to the brain parenchyma. So as I said, this patient probably starts in the area postrema, and then and we can discuss, did he bleed again? Or often at the beginning, patients start with some symptoms, and then as the cavernous malformation continues to leak almost in a continuous fashion, then it tends to enlarge. So then what happens is that they start developing paresthesia in both arm and hands, And that's because of the involvement of the most anterior and medial portion of the posterior columns. And only later on started having leg weakness related to involvement of the most anteriorly placed motor tract. So very nice correlation. And from the history, you can try to understand exactly the location of the cavernous malformation. Very important in this acute phase is that to notice that on, and you see better on FLAIR and T2, but you can see that in this patient, there is quite a bit of edema. And that's a very important concept when we consider the timing of surgery in somebody with, especially with the brainstem cavernous malformation. The other point here is that you can see that, and we'll talk about the T1 versus T2, but you can see here that on at least on this T2 FLAIR, you get the impression that the cavernous malformation might come close to the surface. Now, the T2 and the hemosiderin sensitive sequences like GRE or SWI, they can be quite misleading because they tend to exaggerate the extent of the cavernous malformation. So in order to understand how close the cavernous malformation comes to the surface, really, it's much more useful to look at the T1. We will go on and we'll repeat these concepts because they are important, but just some considerations here as we go through this case. You can see as we scroll and we go toward the lower portion, you can see you catch the bottom of the cavernous malformation still with some surrounding edema. So as I said, the localization here is very important, and I point you to this review article that we wrote several years ago, but it was published in Neurosurgery Focus. But there is a very nice correlation between anatomy, radiology, and the approaches in terms of and the surgical considerations for brainstem cavernous malformations. This is a figure from that article, and as I said, nicely you can tell here that, and this is very important in this case, this patient had nausea and vomiting, so involvement of the area postrema, so the lower portion of the floor of the fourth ventricle, did not have so much symptoms that related to vagal or hypoglossal function. So I could hypothesize, and that's very important in the decision whether or not to do surgery and the risk of the surgery, that the lesion most likely had involved the most inferior aspects of the medulla and the floor of the fourth ventricle, and therefore probably the vagal trigon and the hypoglossal trigon were displaced superiorly. So I felt that from a surgical perspective, that would have been a safer lesion. The lesion involved more of the vagal and the hypoglossal trigon, because you get a lesion that it's in the midline here, and you get both hypoglossal nuclei on each side. Well, that patient, you damage the hypoglossal nuclei bilaterally, that patient is going to end up with a severe neurological deficit. Same thing for the vagal trigon. There are all the implications with breathing and cardiocirculatory function. So as you can see, a lot of considerations that you can make it really just based on what you can infer from the history of this patient, how you can transfer to the location and the function. Here, I like also to stress with this figure a very important concept. When we talk about approaches to the brainstem, when we talk about so-called safe areas, we based our concepts on the normal anatomy. And it is true, if you have a patient with a perfectly normal brainstem, intraoperatively, you can make some of these structures. But the truth is that once you have a bleed, then everything is distorted. There is no vagal trigon, there is no hypoglossal trigon that you can actually clearly distinguish at the time of surgery. So be cognizant of the fact that this disconnect between what is the normal anatomy and what is the anatomy that you will find, especially when we are dealing with the lesion that has expanded and distorted the normal anatomical structures. So here, as I said, very important, the images. So one of the questions from a surgical point of view is that, does the lesion come close to the surface? And again, I like to stress, and yesterday, Michael Lawton in UR rounds made the same point, that the T2 and the hemosiderin sensitive sequences are unreliable. The T1 is more useful in trying to understand if the lesion comes to the surface. But I warn you that no matter how close that lesion looks at the surface, what you'll find more often than not when you go and do surgery, you will find that on the surface, you can have indirect signs of the presence of the lesion. You might see some asymmetric distortion. You might see some brownish, yellowish discoloration, but always be careful. Cavernous malformations usually do not destroy, but rather then displace the surrounding brain, the surrounding parenchyma. So the parenchyma can be massively compressed, but, and I will show you some examples, there is often much more parenchyma than you might think based on the preoperative imaging. So always be cognizant about this and the choice of the approach, and when you are there, how you enter the lesion. So these are all points for that hopefully we are going to expand in the discussion. So when do you operate in a patient like this? Asymptomatic lesions that are purely asymptomatic and they are found incidentally, then there is no indication to do surgery. The natural history is very benign. Those lesions tend to be more established, and this is something that we'll discuss also later on. But somebody like this patient has presented with the bleed. What do? Do you operate after the first bleed, or do you wait for a second hemorrhage? Now, the answer is not that simple, and you cannot give a single answer because, as I will show you, there are, at least in my opinion, there are so many nuances that relate to the characteristic of that patient and that specific lesion to be able to make this decision. And it's really all it comes down to, it's a balance between what is the natural history, what is the risk of additional bleeds versus what is the risk of intervention. And This is probably quite often, actually, it's the most difficult part of the entire process. So let's say we decide that we're going to go and do surgery. When is the best time to consider surgery after a bleed, especially when we are considering a highly eloquent area like the brainstem, the thalamus? I think that there is a fairly good consensus that ideally the best time is probably about 2 or 3 weeks after a bleed. Why? Because you have a part of the fresh bleed that has liquefied, and therefore, as you just enter that lesion, and I will show the video of that patient that we are discussing, you get the fresh blood that is now liquefied that comes out, and that will provide you with a room to then start going around and remove the actual cavernous malformation. Waiting 2 or 3 weeks is also important because, as you saw in the case I'm presenting, there was quite a bit of edema all around the lesion. And when there is edema, then the brain is very friable, it's very soft, and it's more likely to be damaged as you manipulate the cavernous malformation. Now, if possible, why do you like to operate as early as possible? Well, because there is a risk. It's well known that there is a high risk of clustering of hemorrhage after a first one. And again, I think this can be a topic of discussion. Is it true when we see these patients that have a bleed and then they deteriorate over the course of several days? Are those recurrent bleeds, or it's just a continuum where the cavernous malformation starts leaking, and then as it continues to slowly bleed, then that bleeding expands? I think we don't know, but we can get some ideas. And as I said, as long as you have that fresh hemorrhage, that hemorrhage acts as a buffer which facilitate the removal of the actual cavernous malformation. I'm not a great fan of grading systems. I think that they are very useful for research to report our results so that we can communicate with each other. But the truth is that in every individual case, there are so many nuances to consider that it's very difficult to really reduce everything to a grading system, especially when you're trying to decide when to intervene. But in terms of what are some of the most important factors that affect the risk of the surgery, I refer you to these publications by Dr. Lawton's group, where they analyze some of the most important factors in considering the risks related to surgical intervention. So let's go back now to our patient. So we have an 18-year-old with a medullary cavernous malformation. This patient has some deficits, but still has a potential for a good recovery. And by the time he was referred to us, his motor function had already started improving to some extent. He was having, though, very frequent hiccups, and as we know, hiccups is a common sign of brainstem dysfunction. Now, I felt that in this, first of all, at 18, long life expectancy, so the risk of future bleed is significant. And particularly in this location, I felt that this risk of disability associated with an additional bleed would have been very high. On the other hand, as I said, the cavernous malformation seems to come very close to the dorsal surface of the lower medulla. And that is favorable from a surgical point of view. In this case, when you consider your approach, you can see it's just a suboccipital craniotomy and just a midline approach, just by gently displacing the tonsils. It's the lower medulla. Right at the level of the obex, there is really no need to cut the telachoidea. So it's not a true telovelar approach. It's really a midline suboccipital craniotomy. And the other concern I had in this particular case is that, well, I like to wait for that edema to resolve. But I am afraid that if I wait too long, then this tongue of hemorrhage right here might retract, because as the hemorrhage is fresh and then the clots start to organize, eventually will retract. And I knew that there was more parenchyma here than the MRI would imply. So the fact that I was worried that this tiny little tongue of hemorrhage that made the lesion very close to the surface would retract over time was something that was pushing me, if possible, to consider surgery at an earlier stage. So what did I decide? And here again, you can see that, as I said, the T1 are much more helpful, because the T1, they tell us here that there is hemorrhage there is blood of different ages. There is a more ill-defined hemorrhage that is superficial and that is probably more recent blood. And then there is a more established hemorrhage where the actual cavernous malformation is located. Also, again, we go back to the history. I knew that this patient started with the nausea and vomiting, probably related to hemorrhage in the middle, right at the level of the area postrema, and only at the later stage developed paresthesia related to this more recent, fresher hemorrhage. So again, you can see how you can put together the clinical presentation, anatomical location, and imaging findings in the setting of patients' individual data. This is a very young, very active 18-year-old. So again, the main concern in the very acute phase was the edema. So what I decided to do to help me with the timing, I didn't want to wait too long. I didn't want to go in too early because of the edema. So I decided to repeat the MRI about a week, 10 days later, as it started to improve, in order to design about the timing. And actually, that MRI was very helpful, because here is the MRI on May 20. This is the MRI on May 26. And what you can see when you compare the two studies, if you look at the edema, you can see that the edema is slowly improving. It has basically resolved on the right side. There is still some on the left. And you can see how the cavernous malformation and the blood is changing also in consistency, and the cavernous malformation is start forming that hemosiderin rim that is more expression of a more chronic lesion. Same thing here, May 20th, lot of edema. May 26th, the edema start regressing. And as the edema regress, you can see better than, the lesion comes close to the surface, but there is quite a bit of parenchyma right around it. So I decided that, yes, of course, it's a very delicate location, but it was based more in the inferior portion of the medulla. The vagal and hypoglossal trigon probably were displaced superiorly because there was not major clinical involvement of those structures. And therefore, I decided this was a good timing to do surgery, good indication, and we decided to go ahead and do it. Now, some of the critical portion of surgery in this situation is that I was expecting to find some more liquefied blood on the surface. And then I was planning to really enter this hemorrhagic portion of the cavernous malformation in the middle. And when you do that, you remove some of the liquefied portion. And then I learned that it's important to be very patient and not to get too anxious, and just let that brain that has been under pressure to slowly start really delivering the cavernous malformation toward your surgical opening, so that you can keep working through a very small opening and let that compressed brain, once you have the bulb internally, you have removed some of the liquefied blood to deliver that cavernous malformations toward your surgical opening. Another important concepts that I've learned over the years is that, especially when you start at the beginning of the dissection, you get the impression that the cavernous malformation, that capsule, it's very adherent to the surrounding brain. And the temptation is to pull, but it becomes really an art to know how much you can safely pull without causing damage. So again, I tend to evacuate the blood, irrigate internally. Of course, we're doing monitoring, so do motor evoked potential. So all of this gives us some time for the brain, for that brain that is pulsating, to literally squeeze the cavernous malformation toward the internal portion of your surgical cavity. And once you start identifying that plane, you will see you develop an handle. And once you have that handle that you can hold the capsule, it's very important that you don't lose. And here we can illustrate some of these concepts. So here, what is interesting in this particular case, you can see that as we open the dura, and I like to open the dura separate from the arachnoid, as we are opening the arachnoid, you can see that we encountered some bleeding. And interestingly enough, there is a pica branch that you can see here, goes to the arachnoid, and through the arachnoid goes to the dural. So this is a dural branch of the pica that is not very well described, but as we will see in one of the future discussions, it's this pica branch, dural branch, often participates to posterior fossa dural AV fistula, but it's not very well described in the literature.
Dr. Lanzino?
Yes.
Before we go on to the video, we've had a couple of questions through the chat. Is this a good time?
Sure. Yeah, I think so. Let's go ahead and answer the questions.
Fantastic. So the first question came from Dr. Parek, who said, what do you do if there's an acute bleed with an unconscious patient? Would you advocate early surgery?
Yeah, I think that the indications for true emergency surgery in cavernous malformations are rare. I've had patients though were in a situation where they were rapidly deteriorating and was either loss of consciousness or compromise of cardiocirculatory respiratory function, where a rather urgent surgery might be a reasonable option. But always remember, I say the following: dying from a bleeding, from the direct effects of a bleeding from a cavernous malformation, it's extremely rare. So it is very important to use judgment, because patients, yes, they can look really bad at the beginning, but often they have a potential for improvement. And so I think that there are rare cases where a more urgent evacuation might be indicated, but also be cognizant that those are the patients where you're going to find a lot of edema, and the surrounding parenchyma might be quite friable.
Fantastic, thank you. Does that answer your question, Dr. Parekh? If you're able to speak.
Thank you.
Excellent. And then the next question came from Ahmed Risk, and the question is, did you find a DVA? Was it possible to define?
Very, very interesting questions. I will show you. It's very common. So first of all, we know that DVAs are almost always associated with the cavernous malformation, but in the sporadic form. In the familial form and in radiation-induced cavernous malformations, the pathophysiology is probably different, and those cases, they tend not to have a classic DVA. The problem with the DVA in the setting of a bleeding that is compressing the surrounding parenchyma is that it's not uncommon that the DVA might not be immediately visible on the preoperative imaging, but after you remove the cavernous malformation and you remove the compression, then it becomes easier to see on the MRI. In this case, you will see that what I found along the floor of the fourth ventricle is what I felt was probably a partially thrombosed DVA, and I will show in the video. Any other question, Nick?
We've got some questions from Warlix, but she said we could put them to you at the end of this chat. So
okay,
let's go on with the video.
So here what we have a patient that is positioned prone. It's a midline suboccipital craniotomy. Remove the posterior arch of C1 to get a better exposure of the upper cervical cord. And basically what I'm looking from the right side, going to the looking toward the left, as the lesion was eccentric to the left side. So here you can see here now we are moving upward toward the floor of the fourth ventricle, pica loop, displacing the tonsils. And here you can see the obex, and you can see the brownish discoloration of the created by the bleeding in the inferior portion of the floor of the fourth ventricle. So here I'm trying to understand what are the actual boundaries of the cavernous malformation. And then my plan was to open and divide those 5 adhesions at the level of the obex. And then the plan was to do displace the posterior column, working along the median longitudinal, posterior median longitudinal sulcus, But as you can see, you start with the plan, and then I get here, and there was this fairly large vein, and therefore that limited my ability to mobilize the posterior column. So this is a classical example. You go with the plan, but then you have to adapt. You need to be flexible. You need to adapt and change your plan based on what you find at surgery. So here is trying to open as much as possible. Here you can see the area of discoloration. Now I'm going, and I like to identifying the normal floor of the fourth ventricle, looking all the way into the fourth ventricle just by gently displacing the tonsil. So here you will see what I thought was probably a thrombosed what was, you can see here, I thought there was probably what looked to me during surgery, a partially thrombosed DVA. So here, this is a vagal nerve stimulate. It's a stimulator. So what we are doing, we have electrodes in the sensors that are in the endotracheal tube. So we are able to monitor the vagal nerve function. So I'm stimulating what I think is the portion where the cavernous malformation comes closest to the surface to make sure that I'm not in the close to the vagal trigon. And here making a small, it's really an incision parallel to the tracts, and then gently with the bipolar trying to open that very small opening. And you can see now come across the liquid portion of the cavernous malformation. You will see that the surrounding parenchyma, as I said, most of the edema is gone radiographically, but it's still relatively friable. So the next step is to just be patient and gently dilate that opening and let that fresh blood come out, and with the help of the suction there. And then start identifying here more of the capsule of the cavernous malformation. And as I said, once you have the capsule, you develop a handle that you can hold. You can see now with the bipolar gently start teasing some of the cavernous malformation. And then at this portion, it becomes almost like a lumbar disc, where it's a fine balance between a gentle traction and as the lesion starts coming out, keep teasing off the surrounding parenchyma here where there is adhesions, and you can see the interface with the sharp dissection, separate those attachments. You can see that the surrounding parenchyma is still fairly friable, and then gently and develop. Here it's a very important, I'll stop even though, so it's a very important, sometimes I even though don't use bipolar in this stage, but sometimes I like to, once I know I am on the cavernous malformation, I like with low power bipolar to coagulate that portion of the cavernous malformation so it shrinks, and that helps with the separation. But what happens when you start the bipolaring the capsule of the cavernous malformation, then it becomes, as you can see here, becomes white. And then it can become tricky to distinguish the surface of the cavernous malformation from the normal hemosiderin stained parenchyma. So I don't use bipolar because if there is any bleeding, it's low pressure venous bleeding that can often be easily controlled with pressure and time at the end in the irrigation at the time of the procedure. But occasionally I do use the bipolar once I know for sure I am on the capsule to gently coagulate the capsule so it shrinks and it helps with the separation. But when you do that, then the capsule becomes whitish and it becomes more difficult to distinguish. So once I have these forceps that have a round teeth with the diameter of 1 millimeter that are very, very helpful for, especially for this. They were specifically designed for this action. And you can see once the bulk of the cavernous malformation has been separated, then you can pull. And then this is another part where you gently, carefully inspect the cavity. But what I do is with irrigation time, just to let that surrounding parenchyma squeeze the remaining portion of the capsule. This is because of this position. And that's what you want to see at the end. You want to see that whitish parenchyma stained with a thin layer of blood, and then you gently go around and make sure that there are no remnants of cavernous malformation. One of the most difficult part, this is like same thing is for intramedullary tumor, is to strike that balance, how much opening you need, and you try to be very conservative, but sometimes because your opening is too small, you might end up doing more damage than you could have done otherwise just by enlarging your openings. For cavernous malformation, as you saw in this case, you start with a very small opening, but then as the lesion comes out, the opening itself will slightly dilated. And importantly, at the end, you are left with the cavity that is much smaller than the original size of the cavernous malformation, because, as I said, you let that surrounding brain, the cavernous malformation is displacing rather than destroying the adjacent brain. And therefore, you like to, it will slowly, it will decrease the size of the cavity after you have removed the cavernous malformation. Here, we can discuss the role of post-operative imaging. Post-operative imaging, after you have done surgery for a cavernous malformation, it's a very, very difficult, but I must say that if you are really honest and you understand what you did, how much you were able to achieve, if there were questionable areas, you know that you might have maybe left a residual in some areas, and then you combine that with an MRI done within 24 to 48 hours before the post-operative changes start taking place on the imaging, I must say that I'm usually in a position where I can tell if the resection has been complete or if there is any chance or risk of residual by combining an honest appraisal of the intraoperative findings with the post-operative MRI appearance. So here is the MRI done the day after in our patient, and you can see here the opening along the dorsal inferior midline. And then here you can see the concept that I've stressed over and over, is that there is much more parenchyma around the cavernous malformation that that you might think based on the preoperative appearance. So this is again a concept that I cannot stress enough, and particularly when you are dealing with lesions that come close to the surface of the fourth ventricle. I'm talking more about pontine cavernous malformations. Never underestimates the amount of actual floor of the fourth ventricle that separates a hemorrhagic lesion from the surface, even though on the MRI you might get the impression that that lesion it's really coming to the surface. So you can see here again pre and post, and look how much normal parenchyma is around that lesion. So this specific patient, the outcome is that the numbness and the weakness are actually resolved after surgery, and we'll touch upon this for this particular type of cavernous malformation. He continued to have nausea, and again, that was, remember, the lesion was really centered in the area post-strema, but eventually was sent home 10 days after the surgery. So this allows me to make a difference between the so-called hemorrhagic cavernous malformation and I've heard once a great presentation on brainstem cavernous malformation by Professor Konovalov, and he was the first one to make a clear this distinction between what he called the so-called hemorrhagic cavernous malformation, a cavernous malformation like this, and a more established cavernous malformation like this one, where you can see the actual cavernous malformation and the very thick established hemosiderin ring. And this is also very well outlined in Dr. Lawton publication I mentioned earlier in terms of the timing of the surgery. It's a cavernous malformation like this. Most of the cavernous malformation can be emptied by removing some of the more liquid hemorrhagic component. A cavernous malformation like this is one where you really have to work all the way around, separating this portion and where the surrounding parenchyma is really stuck to the actual cavernous malformation. So the difference is that a patient like this might actually improve after surgery, because what you do, you basically decrease the amount of pressure, and a patient like this, it's more likely to make worse by surgery, because you really have to work hard to separate that cavernous malformation. So some of the characteristics of what Dr. Konovalov calls hemorrhagic cavernous malformation that I have shared over the years is that it's not that uncommon, especially small lesions. You're working with dissection, emptying the internal portion, and the pathologist actually might have a hard time to find an actual cavernous malformation, because most that there is there, it's blood of different ages with different grades of organization, and it can be difficult to find the actual abnormal dilated endothelial structures forming the actual cavernous malformation. And as I said, that some of these patients with the hemorrhagic cavernous malformation can actually improve after surgery, like the patient that we are discussing. Nick, is there any question pertinent to? Yeah, we can answer now.
We've got quite a few questions, actually.
Yeah, let's go ahead.
I wonder, in the interest of keeping this interactive, do people want to put their questions directly to Dr. Lanzino? Warlix, did you want to start? If not, I can read them out through the chat. So Warlix has a few questions for you. The first one is, if the patient's in coma, would you consider operating as an emergency, which I think you've already covered? We've had a couple of people now ask, what sort of monitoring do you use? And how do you know intraoperatively that you've removed it all? Do you need to remove all the hemosiderin?
So the monitoring that we use, we tailor to the location of the lesion. We have we monitor the long track, so we do monitoring of motor and the somatosensory evoked potentials. For pontine-based lesions, I do brainstem evoked potentials. And when we are dealing with the, we have the ability to monitor individually some of the cranial nerves, including the cranial nerves that are that are involved with oculomotion. And for the floor of the fourth ventricle, we are able to map the floor of the fourth ventricle by monitoring 10th and 12th and the seventh cranial nerves. So it's a tailored, but routinely we do somatos long tract monitoring, and then we tailor the remaining part to the rest of to the location of the cavernous malformation. Now, we can also go into details and say, well, I think the monitoring is very important as you map the floor of the fourth ventricle, because it gives you, along with the imaging and the clinical presentation, it gives you a higher degree of comfort in deciding where to make that first incision. But the monitoring is like anything else during surgery. You always have to use the monitoring in connection with your surgical impression and your judgment. What was the other question, Nick? There was another question in addition to the monitoring.
Do you, when we operate on the cavernoma, so, but while I listen to your lecture, you say that, so after that we remove the cavernoma and we see the white plane, so it's kind of like for us to differentiate between hemosiderin and brain parenchyma. Is that right?
Yeah. Well, it's of course in highly eloquent areas, you are limited in that you can you just remove the lesion, and you use that surrounding hemosiderin stained brain as a protection and as your limit. I found that of course in this case, the case I presented, I had a very good view into the entire cavity, so it was a little bit easier to assess. There are many situations where you're working in a deeper hole. It's much more difficult to assess. In some cases, it's safe and possible to bring a small endoscope to inspect the cavity. Otherwise, I use what we call the Afflebaum mirror to look around. But there is no question that there are situations where you base your assessment of how much you have removed based on your feel. But you know that there are many situations, especially in the brainstem, where you have blind corners and you cannot be completely sure. I must say, though, that usually once you have removed a large cavernous malformation, if the lesion is out, then you are left with a fairly small cavity. So over time, you kind of get a sense, because if there is still residual cavernous malformation, it's like almost like a tumor. You see that the parts of the surrounding brain are not completely free and to collapse, and therefore you are still working in a fairly large cavity. I think it's a little bit difficult to explain, but there are a lot of things that over time, and unfortunately it comes with the experience by looking at doing the surgery and then looking at the studies afterwards and and following the patients. It's not always that easy to tell during surgery. There is no question about it.
So I have one question that it's from my own experience. I mean, if that patient, he got fully recovery without any surgery, in which in the brainstem cavernoma. In that case that you're talking about, maybe the size is smaller, and then he got recovery by himself, and we did not do anything. Will you still consider to give him a surgery choice, or if you're not, so how will you going to follow up him? How often?
Yeah, that's a very good question. As I said, there is not an easy answer, because this is really the most difficult part for me. It's really to decide when it's a right thing to consider surgery. In a patient that has had the complete recovery, unless the lesion is very close to the surface, and it's and it's in certain locations like the lower lateral medulla, the quadrigeminal plate area. Those are areas where it's fairly safe to remove a cavernous malformation because you can get good access. So in that case, a very young patient, I might consider, but in a patient that has completely recovered, often the cavernous malformation, the blood is reabsorbed, the cavernous malformation retracts toward the middle of the brainstem, then if it's not really close to the surface and there is not a relatively large portion of the cavernous malformation that it's filled with blood that I can easily empty, I would not do it.
So
can I interrupt there, because that question ties in really nicely with another question we've had, which is what is the incidence of rebleed? Because if a patient has recovered fully, then presumably the only reason to intervene would be to prevent further hemorrhages. And how do we go ahead and answer that question of the incidence of rebleed?
I was going next to present some unpublished data from our own prospective registry of over 300 patients that Dr. Fleming from neurology has kept and updated. And the risk of rebleeding after a first bleed, it's about 50 to 60% over, if you extrapolate over 10 years. So the risk of another bleed after a first hemorrhage from a cavernous malformation, it's actually fairly high, and it's probably higher than what most series have suggested so far. You need to keep in mind that as we consider the literature, most serious about the natural history, there are very few true natural history studies where you see a patient and you follow that patient over time. And then even our study has some biases because we removed some of the higher risk patients by doing surgery. The risk is, again, it's what we now quote, what now I quote, it's a risk of about 50%, 50 to 60% over 10 years. There is some evidence for prior series that maybe that risk might be higher over the next over the first 2 to 3 years, and then it goes down. But our data don't seem to necessarily support that. But the risk is, we think it's higher than what has been reported.
Fantastic, thank you.
How often you will follow up those patients?
Yeah, the follow-up question, it's I like after a first bleed, I work with very closely with Dr. Fleming from neurology, so it's our team. We like to repeat another MRI 3 to 6 months after the first bleed, because that repeat MRI, provided the patient has not had any further bleed, that first MRI gives us a baseline. That's how the cavernous malformation now looks like months after the bleed. Afterwards, I think what I tell patients, I say, look, in this location, if we're talking about brainstem, thalamus, I say in this location, if there is another bleed, you are likely to know before even the MRI would show it. So afterwards, I don't think that there is really an indication to follow up. It creates a lot of anxiety. If a patient has no symptoms, more likely than not, we are not going to do anything about, even if we see a small interval bleed. So afterwards, we continue to follow them clinically, but I don't think for a brainstem thalamus is so useful to keep repeating studies over time. Because if there is a problem, then I definitely would do a study, and then you'll know if there is, as long as you have a good baseline for that patient, which is usually the 3 to 6 months MRI.
Thank you, doctors.
Fantastic. We do have a couple more questions. Actually, the most recent question came from Dr. Miller, which is, can you share any pearls about finding the plane in the myelotomy in the dorsum of the brainstem?
I'm sorry? Oh, well, the like the myelotomy, when we talk about spinal cord, this lesion was an upper cervical / lower medulla lesion, the one I presented. It's there is really a fairly decent differentiation between the two, the posterior column, and then therefore in the spinal cord, and you can really split those, divide those PL adhesions between the two columns, and you can get to lesions with so the term myelotomy in the spinal cord is a little bit of misnomer, because you shouldn't be doing any myelotomy. It's just splitting and going down that posterior medial sulcus. And there are surgeons like I can think of Professor Brogi and Oldfield that have shown beautiful in some pictures. I can really go down that track. In the brainstem, I don't have any pearl to share. I'm very well aware that some surgeons have suggested that there might be a safe area along the midline, but especially as you go higher in the floor of the fourth ventricle, you have the posterior longitudinal fasciculus, medial longitudinal fasciculus on either side, and it's, my experience has been such a very sensitive area to any form of manipulation that I would discourage.
Thanks. Have we got time for a few more questions?
Yes, definitely.
Perfect.
I mean, that's the purpose really of these.
Dr. Perec has a few questions. Are you able to join us with audio and ask your questions to Dr. Lanzino?
Hello.
Hi.
Yeah. Yes, Professor Lanzino. Excellent presentation you have given. Wonderful. And in our experience, we find many times the patient recovers and we send them home. And I'm yet to see a rebleed again coming back to this patient. So this question was also in my mind, whether should we operate them or should we wait? So this is your answered case. 50% is a fairly high percentage of the rebleed, but in my experience, it has not been seen so often. Second thing, I would request you to explain if you have found any post-operative complications during the surgery, like difficulty in swallowing or facial nerve palsies or sometimes hemiparesis after this surgery. Are they temporary? If yes, then are they temporary or they are sometimes permanent?
Yeah. So to answer your question about the the risk of hemorrhage, like as I said, the risk of hemorrhage, if you follow the patients extrapolate over a 10-year period, it's not insignificant. The corollary of that, though, it's also that 50% of patients might not experience any additional hemorrhage over a period of, over a long period of time. So there is no question that, as I said, the balance between, in terms of what to do and when to consider surgery, it's a balance between the natural history and the risk of the surgery. In terms of risk of the surgery, yes, of course, there are post-operative complications. Now, you also need to understand that we do surgery when we feel that we can do with a good degree of safety. So it's not that the risk of complications is not there, but we can minimize by self-selecting those patients that we know they are less likely. In my experience in the brainstem, the main morbidity after surgery has been related not so much to hemiparesis or specific swallowing issues. In my experience, has been related to disruption of highly complex integrated systems, particularly as it refers to extraocular motility. There are some patients that have developed internuclear ophthalmoplegia that can be quite disabling. And also patients that refer persistent dizziness and visual spatial disorientation in space over a long period of time. So that, from my observation, that has really been one of the main issues with long-term complications from surgery, and those are particularly seen in those large pontine lesions. And over time, like many other surgeons, I've tried to stay away, if I can, from the floor of the fourth ventricle, because, as we know, it's a very very difficult and highly eloquent area. So I would prefer, if possible, other type of approaches from for those specific large pontine cavernous malformations. And then, again, in terms of the surgical complications, you have to consider, I would not remove the one I showed that is what I call the established cavernous malformation, that it's very stuck to the surrounding brain. So there is definitely some degree of self-selection in the cases that we do.
Thank you. Thank you very much. Excellent presentation.
Great stuff. There's two other questions that we can perhaps briefly touch upon. One is there a complementary role for radiosurgery in a case like this? And the other question was, do you use any navigation?
I always use navigation. My approach to any kind of technological adjuncts during surgery is that if there is anything that can potentially make my surgery safer, better, more accurate, I will use it. It's also true that you don't need navigations in many cases if you go by anatomical landmark. But if there is any technical adjuncts that does not add incredible amount of time to the operation or incredible cost, I would use it without any hesitation. And the first question was about
is there a complementary role for radiosurgery in a case like that?
Yeah, radiosurgery. On purpose, I try to avoid to touch on radiosurgery because it has been a very controversial issue in terms of for cavernous malformations. We do have a very active radiosurgery program, but we have been very cautious over the years to extend the use of radiosurgery to cavernous malformations. Having said that, there have been very good data coming from the Sheffield units from the UK recently, were published in Journal of Neurosurgery, suggesting that radiosurgery might have a role for very selected patients with the cavernous malformations in the brainstem. The main issue with the radiosurgery has always been that, as I said, the natural history of these lesions is not, until now, was really not very well defined. And the data from radiosurgery suggests that there is no protection over the first 2-3 years after radiosurgery, but then after 2-3 years, the risk of bleeding goes down, which tends to overlap to some extent with what were the natural history data that we have had so far. So to summarize, I would say, I think radiosurgery has today a role in very few selected patients with cavernous malformations. I would warn that there has been a proliferations of machines around the world, and radiosurgery is no different than surgery. It's not about the tool, it's not about the technique, it's not about the machine, but it's 95% about the person that is behind the machine. So it's very important that if done and considered, must be done by people that have a lot of experience in this field. If we don't have any other question at this point, I can go on, and I think you might find interesting some of the natural history data that we were discussing. So since 2015, we have tried to enroll every patient we have seen with the radiologically confirmed cavernous malformation in a prospective registry. This registry has been curated and maintained by Dr. Fleming from neurology, who's a world expert in cavernous malformation. So these are data almost a year old now, but when we analyzed, we did the analysis, it's not published yet, last year around this time. There were 328 consecutive patients. These are the demographics. You can see 75% have the sporadic form, and fairly good follow-up with the median of 4.3 years. And this is what we have found. In green are those patients that presented with the hemorrhage, or there were very few patients that presented with the focal neurological deficit without hemorrhage. In blue are those patients presented with seizures, and in red are those patients with an incidental cavernous malformation. So you can see that for those patients that present with a first bleed, the risk of a bleeding over a 10-year period, that's fairly significant, as I mentioned before. And you can see that our data so far don't support that clustering during the first 2-3 years that has been observed by others. However, what is also important to consider is that despite that fairly high incidence of bleeding, here is the modified ranking over time, you can see that the vast majority of these patients have a modified more than 75%. Despite a high risk of rebleeding, they still have a fairly good modified ranking, which means that they're still fairly functioning, which is what has been, so that again stresses even more so how careful we need to be in trying to understand what to do with these patients, because yes, risk of rebleeding is fairly high, but also the majority of these patients continue to be functionally independent at follow-up. And again, this once again brings back the message that cavernous malformation, once they bleed, often displace rather than destroy the surrounding parenchyma. And that is very important when we consider our surgical indications. It is also very important to consider that just because a patient comes to the hospital and it's unconscious from a bleed from a brainstem cavernous malformation, we remove the cavernous malformation, that patient survives but is left with very important deficits. Well, I think it should be always in the back of our mind whether or not our surgery might also have had anything to do with that persistence of significant deficit, because again, the experience is that despite a bleed, many of these patients, they often recover spontaneously to a decent degree of functioning. So I think over time, I came myself to the realization that if possible, earlier surgery is better. At the same time, I'm the first one to say that it's very difficult to understand and to make that decision to pull the trigger if you are really very careful in analyzing your data and you live with these patients afterwards. So here again is to bring that message: never underestimate the amount of normal parenchyma that is around the cavernous malformation. Here you see, you get an impression that it was right at the surface. After you remove the cavernous malformation, you see that there was, still quite a bit of normal parenchyma. That's the reason why this particular patient recovered this sensory function, is because of the some residual normal parenchyma that was still there. Now, I like to touch about just briefly another case, 27-year-old. She has a known brainstem cavernous malformation. And 2 years before, at the single bleed, she has recovered completely. She's doing well. This is her current MRI. She wants to have children. Is there any contraindication to pregnancy if a patient has a cavernous malformation? Well, this is something that we were able to study in our registry, and was published this year in Stroke. And we had 90 women of gestational age. 4 had presented with hemorrhage during pregnancy, but we did not know how many of those people. So our question was, we have a patient that has a non-cavernous malformation. How many of those patients went on with the non-cavernous malformation to have pregnancy? And we had 37 women that became pregnant after the diagnosis of a cavernous malformation. So we knew these 37 women had the cavernous malformation, and they went on and had the pregnancy. And in this group of 37 pregnancies, there were no hemorrhages during cavernous malformation. So this led us to conclude that if a patient has a non-cavernous malformation and presented with often with the bleed, then there is no contraindication if that patient wants to have children despite the presence of the cavernous malformation. Another practical question that comes up is, doctor, I have this cavernous malformation. Can I engage in sports? Do I need to be careful when I play with my kids? Is there any activity restriction? So this is also something that Dr. Fleming and our group studied. And we specifically questioned patients about if they were engaged in any particular activity at the time of the bleed of the cavernous malformation. And the conclusion here was that at least as it relates to aerobic activity, so mild to moderate physical exercise or non-contact sports, there is really no contraindication, and that does not seem to increase the risk of bleeding from a cavernous malformation. there are no data about contact sports or things like scuba diving, and I think in those cases, we cannot make any firm recommendations, but we have to go based on a case-by-case basis. I have briefly, this is a very important topic, and patients always ask, is there any particular medication that can reduce the risk of bleeding? And there are data suggesting some role for statin, propranolol, other medications, but as far as I'm concerned, the most convincing data that there might be a protective effect has actually to do with aspirin in particular, or even maybe anticoagulation. And this is a pooled analysis of different series that we published in Lancet Neurology with some of our European colleagues, actually suggesting that paradoxically aspirin and other antithrombotic drugs might indeed have a protective effect against further bleeds from a cavernous malformation. And that the speculation here was that that might be related to the role of the DVA and the fact that maybe a bleeding from a cavernous malformation might be associated with thrombosis or outflow obstruction of one of the radicals of the cavernous malformation. So I think this is an area of active investigations. And there are there is a consideration about even starting a clinical trial in Europe. I'm not sure about the state of that, but I think this is something to keep an eye. And it's another question that often comes up from patients, elderly patients with the cavernous malformation as cardiovascular issues, needs to be on aspirin. Is there any contraindication to aspirin? The answer is actually not. And if anything, there might be a protective effect of aspirin against the bleed from a cavernous malformation. But this is something for definitely topic for further study. I will stop here. As I said, the intention here is to make this as interactive as possible. I would also welcome any suggestion on how we can improve. As I said, the hope and the dream is that this can be an ongoing series where we can interact with colleagues from all over the world, and everybody can bring and share an interesting case, and then all together we can discuss with as much as possible some support from what is the literature on the topic. Thank you.
Thank you, Dr. Lanzino. Are you there, Warlix?
Yes. Thank you.
Oh, okay. Oh, okay.
So, but he just like, so thank you. That's really amazing. And Dr. Nick just like bring up some of the questions. So it's times like for the panel. So we allow all the panelists, if you have questions or you want to talk or discuss or even like talk about your case, you can like discuss about, bring it up right now.
Well, thank you, Professor Lanzino, for this expected extraordinary presentation and talk. And I still remember that great operations I observed in the OR with you in the brainstem cavernoma. My question would be that, is it the same approach with the spinal cord cavernoma as the brainstem? Would you, I'm speaking or talking about the initial treatment of the patient, that you would wait for the second bleed, or you would wait for symptoms in the patient to appear where you decide to go for surgical intervention, or it's more conservative approach in treatment?
No, I would say that the approach is similar. in the spinal cord, there is a fairly differentiation between a lesion that it's close to the dorsal or dorsolateral aspect of the spinal cord. It's definitely a very favorable lesion to approach surgically. So in that patient, I would not have any hesitation to consider surgery after a single bleed. For lesions that are purely located anteriorly, then the risks are higher in the spinal cord. Also, for whatever reason, we rarely encounter the truly hemorrhagic lesions like in the brainstem. Usually the spinal cord, the cavernous malformations, they tend to be more attached to the surrounding parenchyma. So if it's an purely anteriorly placed lesion, then I would have a more conservative approach than a lesion that is comes close. It's more toward the posterior or posterolateral aspects where you can easily access either through the posterior medial longitudinal sulcus or the root entry zone.
Okay, thank you, Professor. My second question would be, with your operated cases, what was the initial or the first symptom to disappear and the last to persist from the number of cases you have operated, or what's your overview observational deceiving of the symptoms, like the first initial symptom to subside and the last one to resist at the end? Like,
I think it's again, it's always related to the location of the lesion, and it's very, although there is a temptation to consider, cavernous malformations as it's not each lesion. They're not always the same, and I've seen a dramatic, incredible recovery of function with the really significant shrinkage of what I thought was a fairly large lesion without treatment. And then I've seen patients with what I thought was a relatively minor bleed that tend to have persistent disabling symptoms. But the most bothersome symptoms, as I said before, are mostly those related to extraocular motility, function, or dizziness, or another emerging aspects of cavernous malformation, especially those that present with hemorrhage with or without surgery. Some of these patients can develop hypertrophic coliary degeneration that can be quite bothersome over time and can have a delayed presentation. So the symptoms, there is a lot of variability related to location, pattern of hemorrhage, and not every lesion is the same.
thank you so much, sir. Thank you.
We had another question from Dr. Panikar. I don't know whether you're able to join us with audio and whether you wanted to ask your question directly to Dr. Lanzino.
Let me see, I can see some of the questions myself as I scroll the chat. And
Parek, you're there. Parek, go ahead and answer the question. He's a regular. Are you there, Parek? Oh, perhaps he stepped away.
I'm referring to a question from Dilip Panikar. So the question is, what are your thoughts about multiple cavernomas? How often do you follow them, and under what circumstances would you consider intervention?
Yeah, patients with multiple cavernous malformations, the overall approach is really, to simplify, is that we treat the symptomatic lesion. And so if they present with seizure, we try to localize the seizures and identify the lesion more likely to cause seizures if there is a frank hemorrhage. And we do not treat other associated lesions unless you are operating on a lesion and there is one that it's very close to the symptomatic, to the target lesion. and you know that you can remove it with the very low risk. So that's our approach in patients with multiple cavernous malformations. We treat a symptomatic lesion. For the same reason, after we establish a baseline, I personally do not feel that there is a very strong indication to keep following these patients over time with repeated imaging, but you have also to balance that with the patient. You know, some patients feel better if they come back on a regular basis and they have an MRI. My problem with that approach is that, as I said, the indication is to treat a symptomatic lesion. Sometimes you see quite often, actually, in these patients with multiple lesions, there is either a new lesion that pops up somewhere or an asymptomatic bleed, and then for which you don't do anything, and that tends to create more anxiety than anything.
Fantastic. We've actually got a question from the world-renowned center of Southampton, Dr. Lanzino. It's an important question, which is
absolutely.
One of my colleagues has asked, if you're using monitoring introp and the monitoring changes or you lose it, how do you go about handling that situation?
It's my heart. I have an arrhythmia for sure. No, it's a very good question. But that's as I said. Remember, before we were discussing monitoring, I said it's like anything else. You have to put in the context of what I'm doing. The monitor helps me, of course, if you have that feedback that the monitoring is unchanged from baseline. It's a positive reinforcement during a stressful surgery. If there is a change, where I found the monitoring useful is that if there is a drop in the somatosensor and motor evoked potentials, and it's not a complete disappearance, it gives me a way to modulate the amount of trauma that I am, putting on the surrounding parenchyma. There are some tricks with the monitoring. For example, what we have observed, and this has been reported in the spinal cord after acute decompression of a syrinx, you might actually have a significant drop, especially in the motor evoked potentials. When I go in, I evacuate these large hemorrhagic cavernous malformations. As you evacuate the acute blood and you can see that the brainstem deforms and the tracts that might be kinked, you might have a significant drop in the motor evoked potentials. That does not necessarily mean damage, but it's somehow related to that sudden change in the during. So I use the monitoring during surgery to give me some positive reinforcement when everything from a neurophysiological point of view is going well. And I found it very useful psychologically. And if there is a change, then it's very important to be honest with yourself and to identify if there is something you are doing that has triggered that change. And if it's something that you might be doing, then you can modulate the amount of trauma, mechanical trauma. The most difficult part is that you get to situations where you still see some cavernous malformation, and as you try to remove, you see a drop, a change in the neurophysiological monitoring, and there it's a very difficult line. Are you going to stop? Are you going to continue? And I don't have an answer in those situations. It becomes very, very difficult right there to make an immediate decision. But what I say with monitoring, it's like any other technical adjunct. Ideally, we would like to use monitoring only when we need it, but I found it's useful for me to use it all the time, because that way I can, myself and my team, we can easily recognize if there is a change. Is it a real change or is related to some technical issues, or it's a fluke? Or as I said, we have learned that as you go and you have really done minimal manipulation, but you have evacuated a large portion of a liquefied hematoma and you have a drop, then we know that actually that's not necessarily a negative thing. It might be positive thing just related to the sudden decompression that might not necessarily have a functional consequence.
Brilliant. Takashi Kon, did you want to put your question to Dr. Lanzino next? If not,
there is a question when you are separating tonsils.
Dr. Takashi Kon from Japan, Tokyo. Yeah.
Yes, go ahead.
Okay. Okay. Yeah, okay, thank you. Thank you for a great lecture. Some of them are bleeding repeatedly. So even though asymptomatic, repeating hemorrhage region do you have? So do you consider the priority of removal? One is brainstem dorsal, and the other is the right temporal. Right temporal one bleeding, repeating bleeding, and brainstem one is a small bleeding but no symptoms. So when you have the multiple cavernous angiomas, do you have the priority of removal as surgical consideration? Which do you consider the priority?
Yeah, I would target the one that I think is the most dangerous, especially if I can remove it with the very low surgical risk. You know, it's always that fine balance between the perceived natural history and the perceived risk of that surgery. So I would go for the one that I think it's the most dangerous, especially if I know that I can remove it with the very low risk. Now, the supratentorial cavernous malformations, as I said, dying from a bleeding from a cavernous malformation is extremely rare, almost unheard of from the direct effects of a bleed. So a supratentorial cavernous malformation that is anterior right frontal, even if a patient has had a couple of bleeds, I don't feel so strongly that should be removed, because I know that those tend to be very benign lesions. If a patient is having seizures, then I tend to be more aggressive if the cavernous malformation is easily accessible, because the outcome of surgery for cavernous malformation in patients who have seizures are very, very good. Often those seizures, they tend to be refractory. And often in many locations, you can actually remove not only the cavernous malformation, but also some of the hemosiderin stained brain around it.
Thank you. Thank you. In sense.
Any other questions from the audience?
Okay, if you don't have any questions, then I think we can conclude. John, do you have any remarks? Or
yeah, excellent start. I like the model. I like the interactivity. I'm not a neurosurgeon, but I can see when a panel is cooking, when it's doing, and it really helps to have someone like Nick and Warlick that really know the questions and can maintain the flow. So it's good to have someone kind of quarterbacking with us.
Agreed. I saw there was a question about, what do you do to protect the arteries, especially as you're going in between the tonsils? I thought that was actually a very good question. In the videos I didn't show, but every time, the first thing I did as soon as I exposed the floor of the fourth ventricle, I put a very small cotton ball in the just to plug the access to the floor ventricle, so you don't allow any blood to go into the fourth ventricle and potentially cause obstruction. And then I do use some telfa patties to protect the brain, and I tend not to use fixed mechanical retractors for a lot of surgeries. So in order to minimize that continuous contact between usually the section of the bipolar and the surrounding structures, I tend to use Telfa patties to protect those structures.
Okay, Dr. Lanzino, do you have a topic for the next one?
Yeah.
It's in 1 month, correct?
Yeah, in 1 month, and I think we have some cases. One is again, I think it's important to select cases that are not too exotic, or cases where everybody can relate. So I think we have a case of a tentorial dural AV fistula that it's interesting to discuss and to show. And then also we have a case of indication for bypass because of ocular ischemia. So those are probably the topics we would concentrate next time.
Okay, very good. We look forward to that. We'll make the banner. Warlix makes the banners as well as announcing. And so we'll see you in about a month. And thanks everybody for coming. Thank you, Nick,
thanks,
for the help and Takashi, thanks for Radab, Wong. Thanks everybody for coming. And stick around to network.
Thanks everybody.
Thank you.
Yeah, that was good.